Hello, everyone. Welcome to the first webinar of a six-part series on opioids in the hospital, addressing inpatient harm. My name is Michelle Bonson, and I serve as a clinical quality consultant on the Compass HIIN team. I'm so glad you're here today, everyone. The goal of this particular series is to provide all of you with standardized and evidence-based approaches to reduce inpatient adverse events related to opioids. We have a couple of brief housekeeping items to cover before we start our session this morning. We ask that you please take a moment and check your phone lines or computer audio and make sure you are muted. We appreciate your attention to this as it does help us avoid background noise during our session. We also ask if you need to step away for this session today, please avoid placing the call on hold so we don't have your call waiting background music playing during our webinar. We expect that many of you will have questions as we move through the session, and we actually welcome those. So please utilize the chat box throughout the webinar to type in questions as they come to mind. We'll be sure to answer all questions submitted through the chat either during or at the end of the session. And I would just like to remind everyone that when you are posting something to the chat, there is an option to submit to the panelists or the attendees, or all panelists and attendees, and I would ask that you please select all panelists and attendees for any responses. If you would like to speak during our webinar, please utilize the raise hand symbol and we will unmute your line to allow everyone to hear you. Lastly, this session will be recorded and transcribed. This is helpful for those of you that may want to go back and review a particular section of today's discussion. Before we dive into the presentation, let's take a few minutes to go over the agenda for today. We will start with the welcome and introductions, cover some announcements and the plan for the series, and then move into setting the stage, where we will delve into the impact of opioid-related adverse events and have some general discussion about pain. After that, we will move into a review of the HIIN inpatient opioid measures and close with a resource review and next steps. I had the opportunity to introduce myself. Now it's your turn. Please take a few moments to type your name, the name of your organization, your role and/or title, and your favorite summer activity in the chat box. After our extremely very long winter, I think it's only appropriate to pause and have a moment of appreciation for warmer days ahead. And if nothing else, it helps us all get to know one another a little bit better when not all in a room together. Ooh, we've got some campers. Lana's a camper, Jill's a camper. We've got a golfer, and Sandy likes to hang with her grandkids, gardening. Tennis, awesome, Dino. Well, feel free to continue to enter your information as we go on. I really appreciate you being willing to kind of share your favorite thing to do. It kind of is a little bit of an icebreaker here for us. As indicated prior, this is the first of a six-part webinar series. You will note that the schedule includes a one-week break during the week of July 1st to allow for some time with family and friends over the holiday. Portions of the series may be comprised of a mix of presentation and work time. In other words, the presentation may run for less than an hour, with the remaining time allotted for gathering information around your current practices, finding out where data is housed, how you get to it, goal setting, and other miscellaneous activities. Really, the goal is to provide you with ample time to both absorb and act with minimal time spent outside of our time together. So trying to be a little bit more efficient with this and considerate of your time. Some of you may have wondered about the commitment of participation, which is on the second page of the flyer. You don't see it up on the screen, but you did probably receive it when you looked at the flyer. This is an informal agreement that helps keep leadership apprised of your commitment to learning and implementing concepts or interventions within your hospital. It allows for dialogue around what your goals are relative to decreasing opioid-related harm. And it really ensures engagement and action. We want you to take something away from this series and act on it. And the final thing is it involves a willingness and openness to sharing. This is what it's all about. I will look forward to your comments, your learnings, and some of the things that are taking place in your hospital as we go through this series together. Following each session, registered attendees will receive an email with a link to the recorded version of the webinar. And if you have a peer that didn't register but is curious about attending future sessions, please reach out to your clinical quality consultant for guidance. And are there any questions that I can answer before we move into the next topic on our agenda? Okay, I see a lot of great things out there with what people look forward to doing this summer, but I don't see any questions, so we'll move ahead with our webinar. This jumpstart is going to be narrowly focused on opioid-related inpatient harm. However, I think it would be remiss to not provide a brief overview of the opioid crisis in general, as prescribing begins and often continues somewhere, possibly outpatient, possibly inpatient. The key takeaway is we need judicious oversight and management of patients who rely on us to keep them free from harm while under our care. As evidenced by the data in this slide, impact, momentum, and the ongoing challenges with opioids continue to escalate. The cost to our nation is referred to as the economic burden. This includes the cost of healthcare, lost productivity, addiction treatment, and criminal justice involvement. What is not stated here is the personal impact to families, friends, coworkers, neighbors. At some point or in some way, each of us has or will be touched in some manner by what is often termed the opioid epidemic or crisis. We identified within the Compass HIIN that we have room for improvement with inpatient opioid-related ADE rates, and we heard from a HIIN focus group held earlier this year that they wanted more education and assistance relative to inpatient pain management, thus the premise for this jumpstart. Having said that, I think it makes sense to take a step back and set the stage for why this is important to each and every hospital. It's really more than changing the trajectory on your run charts or other data monitoring tools. It's because harm happens, and part of reducing or eliminating harm is assessing risk and mitigating it. Let's talk a little bit about risk, and I want to provide you with some points to ponder. Perhaps you're fortunate to have avoided a serious safety event, but maybe you've noticed increased activation of your rapid response team as a result of opioid-related sedation or respiratory depression. Do data suggest that there seems to be too frequent use of unplanned opioid reversal agents? And if not data, do you ever have an inkling that that may be happening? Maybe you've noted too high doses of opioids or an incorrect PCA setting and the errors were caught. But what if they hadn't been? I'd like to ask that you use the chat box right now and let us know if any of these particularly caught your attention or caused you to pause. If not these, was there something else? So as you kind of think about it, tell me what you think. Not seeing much in the chat box, and that's okay. I understand sometimes it's difficult to kind of throw yourself out there and put your comments in, and that's okay. This is our first time together, and I anticipate that as we move along, people may feel more comfortable. But I would like to let you know that if any did catch your attention, you're really in good company because the patient safety momentum has been going strong for over 2 decades, and the momentum continues. This momentum now includes decreasing opioid-related adverse events in all settings. Opioids are the most commonly prescribed class of medications in the hospital and the second most common class to cause adverse events. Respiratory arrest and death related to opioids has incidence that is hard to measure, but it's real, as evidenced in case reports. You can see on this slide the death rates related to PCA. In the same report, it was noted that more than 56,000 adverse events were linked during the same time frame. These events include, but are not limited to, respiratory failure, unplanned mechanical ventilation, reversal agent administration, and unplanned transfers to the ICU. Recent literature correlated increased mortality, spend, and length of stay in patients undergoing surgical or endoscopic procedures. Other findings included these patients experienced greater likelihood of discharge to another care facility and a higher rate of 30-day readmission. So we can't really ignore the hard costs to the system relative to opioid-related adverse drug events. They drive the bottom line and contribute to avoidable costs regardless of hospital type, size, or location. And you can see the cost and the expense here in this slide, but I want you to remember that we can't lose sight of how devastating the impact of an adverse event is to patients, their loved ones, and equally important to all of you. You're the people directing, providing, and overseeing care. And when harm happens, it's hard. It's hard on caregivers, and I want to acknowledge that. Let's just pause for a moment, and I'm going to review the chat box. What thoughts do you have this far? Anything you found particularly interesting with the data? Are any of you surprised by the cost? Great question. Betsy has a question there. Are there hospitals who are considering getting rid of PCAs altogether? Tony, this is related to inpatients only, not ED. Yeah, I know. I agree, Brooke. It's quite expensive, and I think that there's some of the things, like I said earlier, it's the, I guess, soft costs. So it's the things that we sometimes can't put a number to, but it's those impacts to people, right? And it's having to go for extended care and treatment somewhere else, and it's just what happens to them after a harm occurs. So are there any hospitals who are considering getting rid of PCAs altogether that are on this call today? Well, if you are one of those hospitals or you have information, oh, hi, Sandy. Yeah, anybody looking at pain contracts for inpatients? We know that there's been a heavy emphasis in the outpatient world, definitely. Thanks for that, Tanya. So Tanya, they say they haven't gotten rid of them. Rarely used, but mostly on hospice patients. And you know, the PCA should be double checked for the right dosage, Tony. And as we move along in our series, we will talk more and more about best practices and sort of how to incorporate some of those things and an assessment to see how your facility is monitoring accordingly. One thing I found particularly interesting when preparing for this session is the importance of tying the inpatient setting to other settings as it relates to opioid management. It feels as though it's been lagging a little bit in some respects, but the momentum is changing, it's ramping up, so it's a perfect time to take part in this series. Speaking of ramping up, there are a few things I want to bring to your attention as it relates to pain management. There's direct correlation between normalizing the practice of inappropriateness of overprescribing of opioids, with pain being assigned status as the fifth vital sign, and pain control as a barometer of patient satisfaction. And I know that you all know this all too well. In 2017, representatives from select leading health systems met in Nashville for a two-day perioperative management collaboration summit. And their mission was to examine clinical evidence, best practices, and outcomes data, and then apply that knowledge to develop organization-specific strategies for implementing modern multimodal approaches to managing surgical pain. So what common theme do you suppose emerged from that meeting? Using your chat box, just enter the common theme you believe emerged. So we have a bunch of experts getting together in Nashville. They're talking about what they need to do, and they sort of came to this aha moment. And again, there's no right or wrong answer. I'm just curious to know what you thought perhaps emerged from that meeting. I see patient education, excessive opioid use and inappropriate use. Joni, that's a great one. Caused by medical professionals and prescribing methods. Not a fifth, great. Great insight, everyone. What the answer was, and these are all probably a portion of that, because I would envision that they did discuss many of those things, but every single attendee knew a person admitted to the hospital for a simple procedure and was discharged with a significant dose of opioids. And some of the stories that they shared ended tragically, some moving from prescription to street drugs and sharing or selling to friends, family, or strangers. So I think you can see, based upon your responses, that probably many of those things were discussed, and in the end, that's what they came to. So pain management as a barometer for patient satisfaction has since been scrutinized. There was a proposal to revise pain-related HCAHPS questions, which most recently resulted in CMS announcing they will remove the revised communications about pain questions starting with October 2019 discharges. And more information about that HCAHPS changes can be found at a particular site. And I thought I could enter it into the chat box, but I am not able to at this moment, but I will make sure that I get it out to you if you were looking for that, because I didn't delve deeply into the HCAHPS, but I wanted to make you all aware that those changes were in play. And for those of you that aren't familiar with the term multimodal, a multimodal approach to pain management involves using two or more different methods or medications to manage pain rather than opioids alone. And we'll talk a lot more about that, but since I used that term, I wanted to be sure that I covered it. In a Health Affairs article dated September 8th of 2017, the writer spoke to the case for confronting long-term opioid use as a hospital-acquired condition. And the premise was long-term opioid use that begins with a prescription for a self-limited problem fits the CMS definition of a hospital-acquired condition in every respect. So take a look at the slide we have here, and use the chat box to let us know, I guess, the entire group, how you feel about this. You know, do you agree? And if, why not? And again, there's no right or wrong answers. A lot of this is just engaging in some conversation, which I typically really like to do with people face to face. So you will note that I will have a lot of chat activity usage during my webinars. So what do you think? What do you think about opioid use as a hospital-acquired condition? Excuse me. So if there's high cost, it's a high cost condition, it can be reasonably prevented. It's a high volume condition and it arises during hospitalization. I agree, Tony. So I think it does, in my personal opinion, I think it meets the definition of a hospital-acquired condition. Thanks, Tanya, for saying that. Yes. So some of the patients do come to the hospital having already been taking them for years for chronic pain management or whatever the case may be. But I think when there is an event that occurs during the course of the inpatient stay that is a result of something delivered to the patient while under your care, I do believe that that meets the intent of a hospital-acquired condition. Betsy, I think that is such a great comment. It's really hard to hear because you know what? It is true. It's a fine balance, right? I'm an old nurse. I'm not going to tell you how old I am, everyone. But I can tell you that, you know, I was of the give them the medications. You know, they aren't going to be able to get up and walk if they don't have the medications, and then they're too sedated to walk. But, you know, really pain management through medications was what I was taught and what I knew for many, many years. And we're going to talk a little bit more, Betsy, about sort of how we're going to have to rewire patients' thinking around pain. Thank you, everyone, for being so engaged. I really appreciate it. So that same Health Affairs article, as well as many other reputable sources, emphasize the importance of resetting patient expectations of post-procedure pain and pain relief. Okay, so it's easier said than done, right? We kind of just heard about that a little bit in the chat box. The fact is, when our bodies are subjected to unusual or non-routine impact, we hurt. So this can occur with exercise. Maybe you slept wrong on your pillow and you've got some poor neck alignment and you wake up with a little crick in your neck. You've been in cramped quarters for an extended period of time. Just think about, you know, sitting on the airplane and when you stand up. But why should something as invasive as surgery be any different, right? So pain happens. I guess that's what I'm kind of trying to say here. And there are imposed regulations that will require a shift in opioid prescribing. But the things on this slide are the things that will require both a societal and institutional shift. And this is not an exhaustive list by any means, but as you can see, they involve a different level of engagement with patients. Using the chat box, what are some things that you think are necessary to counteract or prepare for issues that arise with acute pain management? Perhaps there are things you're already doing. Share away. I see many things on there about education, and I think that that's accurate. And I think it needs to be done before they enter into that situation as much as possible. So if you think about patient and family engagement, if patients are coming in for a procedure and you actually engage them prior to the admission for that service, you should be talking about pain management at that time. You should be talking about what is it that they do to manage their pain typically. You know, if people are already on opioids, that's one thing, but I can share with you an example of a friend who went in for a procedure and they did not talk to her about what it is she wanted to do, but luckily she is a nurse by background. She had done her research and she said, you know what? I want to manage it with Tylenol alternating with ibuprofen. I don't want any opioids. I can do this. This is how I want to handle it. I've done a lot of research. So she initiated that. So we might see more and more consumers as they become more engaged and aware. But I think we on our side need to make sure that they are aware of some of the opportunities that exist, and we really work with them rather than prescribe to them. Oh, great, Betsy. So you have the pain menu. Great. The comfort menu, aromatherapy, massage, music therapy, etc. Great. And these are things that if some of you participated in our opioid guardianship project last year may have been exposed to. But if you hadn't been, I'm just going to take a moment here because we're talking a little bit about this, and I'm not going to delve into it. I just kind of want to expose you to it because we will talk more about these in the future. But if you've not seen a comfort scale and a comfort menu, I think it's important to share that with you. So I'm going to do that right now. So this is a comfort scale, and what you'll notice on here is there's no rating of pain. Obviously, there's no pain scale. And it's really helping people be able to talk about whether or not they're comfortable and the degree to which they're comfortable. And it also has the bases on there that people can assimilate with and sort of go, yeah, this is kind of how I'm feeling. And I really like this, and I know many of our hospitals have implemented it, and we'll talk more about that, like I said. And then I think we had Betsy talking about a pain menu. And I'm going to bring that up right. Oops, that's the wrong one. I apologize. It's actually this one, and this is a comfort menu. And as you can see here, it talks about comfort, personal care, some comfort actions, relaxation, and medication. And this is to be done with the patient. So if you haven't seen one of these before, I would like you to know that at our IHC website, you can obtain these. And so that is something that is available for everyone. And if you have any questions about that, feel free to reach out and we can assist you with getting a hold of those. All right, let's move along here. So before we move into a focused review of the HIIN measures, I wanted to be sure to remind you all that this series is about tests of change. It's really about setting a framework and providing tools and resources to identify low-hanging fruit, as well as setting you in the right direction to continue to test and refine your actions and your interventions. You know, sometimes it's not easy, and it's probably not going to be a one-size-fits-all, but it will be with the aim of less opioid harm related to opioid administration to your patients who are inpatient. This is the first of 2 HIIN opioid-related inpatient measures. And statin naloxone administration inpatient is a self-reported HIIN measure. Hospitals are requested to report their data on a monthly basis to allow for more real-time monitoring and analysis. This table that you see in the slide is an excerpt from the Compass HIIN Metrics and Measurement Toolkit, and a link is in the bottom of this slide. You don't need any special access to obtain it. It's actually out on our website, so I encourage you to look at it. And what I'd like to pay particular close attention to, because I think that there's been some misunderstanding in the past, is that the numerator is really the number of doses when a reversal agent is administered to an acute care SNF, swing bed, and observation patient who has been prescribed and administered opioids during their inpatient stay. So there's 2 key things there. They need to be prescribed during their stay and administered during their stay. And when that occurs and naloxone is given, they meet the intent of the numerator. And then your denominator is the number of acute, SNF, swing, and observation patients prescribed opioids. I want to emphasize that this is inpatient, prescribed and administered, and you're going to exclude ED and others who are not inpatient status. Betsy, you have a question. Surgical patients are excluded for the purposes of this HIIN measure if they are an inpatient, they would be included, but your outpatient surgical is not included. We do have some hospitals, some of the larger hospitals, who may take direct admits to their hospital where they are continuing care from an opioid overdose that's being reversed that occurred outside of their hospital. So it was probably self-administered. People were taking opioids, overdose, showed up in an ED. That hospital maybe was not equipped to handle that patient, so then they were a direct admit. Those patients would not count in your numerator because the opioid was not prescribed and administered during their inpatient stay at your hospital. As part of participation in the Compass HIIN network, hospitals are able to access several reports. Two we will discuss are the dashboard and the run chart. So the HIIN dashboard provides a stoplight view of current hospital progress toward HIIN program goals. And the de-identified dashboard in this slide tells a hospital a few key things. And hopefully it's big enough for you to see. And you do have the slides, so you can kind of go back and take a look at this. But what you will see is that there is an up arrow here in the improvement section. And that means that this particular hospital is meeting the improvement goal of 20% reduction in harm, okay? And so you can see the time frame for this at the bottom is from January 2018 to December of 2018. And it's being compared to the baseline right here of January 2014, December of 2014. So their current numerator and denominator was this. So they had 9 events. Their baseline rate for this same measure in 2014 was 0.83, and their current is 0.36. So thus the green and the arrow. Their peer average, which means like hospitals, is 0.37. So they're below their peer average. And then the overall HIIN average, which is all hospitals reporting to the Compass HIIN, is 0.30. What I'd like to really talk about is this facility value estimate below. So what this is telling you right here is that because of the work that has been happening, or maybe it's just changes of policy, procedure, practices, during this time period in the comparison to the baseline, they've avoided 12 events. They've saved just over $67,500. They've avoided a length of stay of just over 37 days. And then you can see their excess mortality avoided is 0.15. And so I just wanted to show you that this is available to hospitals, and I think that this is a great tool to be able to kind of see what is this costing you, both in true dollars, perhaps, or actually the impact to patients. Run or control charts are graphic displays of data points over time. I'm sure many of you are used to looking at these. These are customizable for our HIIN hospitals. They can add an upper and lower control limit, add a trend line, add data point labels to the run chart. What is not visible in the example here, but would be if there were any notes, findings, or interventions for a particular reporting month. So on this one, you can see that the hospitals, their facility rate is in the blue. And then the HIIN average is always included. So the HIIN average is running, pretty low here. And this is January through March. But this hospital's had a few hiccups, but overall their trend line is going down. And I spoke just a minute ago about what you don't see is if a hospital during their reporting time finds a particular incident or they've done a root cause analysis, let's say for September for this hospital, they looked at this one case and they wanted to put a little note in there so they would have a reference, whatever the situation may be. I'm not going to make one up right now, but basically something that will help them remember that they reviewed that case and sort of what the outcome was. We would ask that you don't put any PHI in here, just a little brief note that will help you. Also, there's an opportunity to write in any interventions that you've started as a result of this. So as we know, sometimes people move from role to role, and so this allows somebody new to come in and historically look, or maybe you need to historically remember, so you can capture that in here. You don't see it in this one because this particular hospital did not have any notes, but just know that that is visible if you do add those. And it's a free text area. The second of the two HIIN opioid inpatient measures is the opioid-related adverse drug event rate. And this is data that comes from the inpatient state database, or IPOP data, and therefore is claims-based. So this is not something that is self-reported. The frequency by which your organization reports dictates how readily available your data is. We highly recommend you report monthly. Again, this allows for more real-time monitoring and analysis. And you'll see here by the numerator, it's the number of patients with a non-present on admission secondary ICD-10 code for opioid-related adverse drug event. And the denominator is the number of discharges for acute care patients greater or equal to 18 years or older. And a list of the non-present on admission ICD-10 codes can be found in the toolkit. Again, that link is at the bottom of this page. This is a new measure starting in April of this year. However, we have historical data due to the fact that it is claims-based. So we added it to be visible to our HIIN hospitals starting in April, but know that any data that you've been submitting to IPOP, it will show up in your prior data as well. Here's an example of a run chart for this measure. You can see that this particular hospital did have one event in January. And this measure specifically does not show up on the HIIN dashboard at this time. This is a new measure for us, so we continually evaluate the status and kind of what's happening with it. And also we need to coordinate with CMS which measures we are going to place on a dashboard. As you know, we are under a grant, and therefore some of the things that we need to do within our HIIN related work is subject to CMS review and approval. Now that we've reviewed the HIIN measures, I really have a few things that I'd like to ask you to do. I know it's summer, but I've got some homework for you following this webinar. I would like to ask that you go and review your self-reported stat naloxone inpatient HIIN data. I want you to review both the dashboard and the run chart and write down some key findings. I want you to pay particular attention to the HIIN self-reported stat naloxone numerator and denominator criteria to make sure you are reporting according to the specifications. HIIN participating hospitals must report on all required ADE process and outcome measures, and this includes inpatient naloxone administration. So if you're not reporting to the HIIN, is there another place you're currently capturing the data and monitoring it? Could you get to that data? I encourage you to really think about reporting if you're not, or thinking about how you can get that data, because opioid stewardship and guardianship is only going to continue to grow and expand. And in the absence of baseline data, it's going to be really hard for you to know if you're on target. I think we all agree that if you don't know where you start, it's kind of hard to know where you're going. And I want to put in just one caveat relative to the mandatory reporting part of this measure. If you're not currently able to accurately collect and report, please get that in place prior to entering data into the portal. The other thing I would like to state is that your clinical quality consultant is available to help you correct any data that maybe was inappropriately placed or entered into your actual database actually into the HIIN portal for this measure, specifically that self-reported one. So if you've included ED patients or you've included, things that don't meet the numerator and denominator, please reach out to them and they can help you get that corrected. I'm going to pause now. I've been talking for quite a while. I want to check the chat box for any questions before we move into the final part of the presentation today. So what questions do you have? I will do my best to answer them, and please know that if I don't know the answer, I will research it and we'll make sure that we get the answer out to everyone. So Betsy, you had a recent administration of naloxone that was several hours after surgery, and your clinical opinion was that the patient's respiratory depression was not due to narcotics. You did not report that administration of naloxone. So I don't know the situation, and I don't want to ask that you release any, PHI or anything like that, but I guess I would ask that, were you able to truly rule out that in fact that was not related to the opioids? And again, I trust your clinical opinion. Let me just say that. You are there, you're with your patients. Okay, great. I think that's important to know. So you were monitoring this patient and they did not respond to the naloxone. And I would just ask for all of you to use your best clinical judgment for these cases, because the other thing that can happen that I've witnessed or experienced in speaking with some of the hospitals that I work with is sometimes people are quick to administer the naloxone, right? So it's available and it's quick to administer. Somebody might be just a little bit sleepy, and there's sort of this rapid response that happens. So some of those cases are good to look at too. So not only was the naloxone given, but was it appropriate? You're welcome, Betsy. Sandy, at this time, I would say that that is not included in the measure. Okay, so you guys all have your homework, to go back and look at your data. During the course of this series, I just wanted you to be all of you to be aware that I'm going to be using various resources and points of reference, and my goal is to really provide you with links on the actual slides relative to that specific content, or include a separate reference page so that you're able to access the materials. You will note that the reference page for this presentation is located at the next slide, so we'll touch on that in a second. But having said that, I can tell you that some key resources I will be using are noted in the slide in front of you. I will intentionally point out common themes across various references when available and appropriate to draw attention to best practices. Because this is intended to be an interactive and learning and action forum, I welcome your input on what is working within your organization at any point in our time together. I will also state that if you haven't begun focused work in this area, that's okay. Learning is the first step toward action. So I don't want anybody to walk away from here feeling as though you're behind the 8 ball. You can get started today. You can get started tomorrow. So these are some of the resources that I will be using. This is the reference page I just spoke to. Feel free to peruse it at your leisure if you'd like more detail. So again, sometimes there's information actually in the slides, but I do like to provide you with my references. Before we move into next steps, let's just check the chat box again, and feel free to post any comments or questions that you have about what we've discussed today. Anything that you've learned. Thanks, Dino. I appreciate that. So hopefully you all received the slides. Our goal is to always put out the slides in advance. Thanks, Lana. Oh, Betsy, thank you. I appreciate that. Our goal was really to sort of set the stage today. And so I'm glad that that met the intent. You're welcome, Tony. You're welcome. Feel free to continue to add things to the chat as you want. We'll kind of move in here. So as we draw to a close, I just have a couple of reminders for you. Remember to do your homework. If you find that some of your data report of the HIIN is not in alignment, again, I'm just reiterating that because we've found that as we've been working with hospitals. Please reach out to your HIIN clinical quality consultant for assistance. And if you are on this call and you are not aware of who your HIIN clinical quality consultant is, feel free to email me. Maybe you are not the person that actually enters data as part of the HIIN program participation. If you aren't, feel free to reach out to your director of quality or your HIIN coordinator. They can help connect you as well. So I just wanted to let you know we're here and we are here to help you. We want you to have the best possible data available. And then I want you to take some time to reflect on what you learned today. You know, share something specific you learned with a colleague or a manager and really start to think about your organization's culture relative to patient safety. Think about your barriers and opportunities and also your successes. I'm a big one on successes because if we talk about barriers and opportunities, and when I say opportunities, maybe things aren't trending the right way, I think that we forget to sometimes celebrate the successes. So I'm kind of a cheerleader here. And when I come out to your hospitals, as I know my colleagues do, we always want to talk about your successes as well, because it's important to recognize the work that's being done. And I think this is all going to be important as we move forward in our following sessions together. And one last thing I want to say, you can't boil the ocean, but you can boil a cup of water here and then a cup of water there. And then pretty soon you've got a pan of boiling water. So things are moving along. So just remember, take some time and just don't be overly hard on yourself, but just start moving in the right direction. Thank you so much for your time today. I know it is precious. I know many of you wear multiple hats. You will receive an email with links to this presentation. If you have any questions prior to our next webinar on June 12th, please feel free to reach out to me or your assigned clinical quality consultant. And if you haven't signed up for the next webinar, please be sure to do so. Have a great rest of your week, everyone. And thank you for your time.